Hello, I am Dr. Jonathan Kay from the University of Massachusetts Medical School in Worcester, here at the ACR Convergence 2020. Well, I'm really in my office at home, having spent the past 2.5 days looking at the absolutely fantastic sessions that have been presented virtually by the American College of Rheumatology. I miss the in-person interactions that we have at the annual scientific meeting, but with the ability to zoom in and see other people virtually and watch the presentations from the comfort of my own home, I've been enjoying this meeting and hope that you have too. I'm going to focus today on presentation 1445, an abstract presented at the third plenary session by Dr. Vijay Joshua from the Rheumatology Unit at the Karolinska Institute in Stockholm, Sweden. He talked about citrulline reactive B cells present in the lungs of patients at risk for and with early untreated rheumatoid arthritis. Interstitial lung disease in rheumatoid arthritis seems to be a theme at this meeting, with a number of abstracts, posters, and oral presentations about interstitial lung disease in patients with rheumatoid arthritis. On Friday, we saw the presentations by Jeffrey Sparks from the Brigham and Women's Hospital in Boston, Massachusetts, where he talked about the increased prevalence of interstitial lung disease among older rheumatoid arthritis patients, where about 5% of them were found to have interstitial lung disease. He also talked about the fine specificity of anti-citrulline antibodies to predict interstitial lung disease, especially antibodies against citrulline fibrillin. Now, the citrulline reactive B cells have been identified in synovial tissue, synovial fluid from patients with rheumatoid arthritis. And interstitial lung disease has been noted both in patients with rheumatoid arthritis and also in patients at risk for rheumatoid arthritis. In the studies of the etiology of rheumatoid arthritis, or SERA longitudinal cohort, which is comprised of first-degree relatives of probands with rheumatoid arthritis who also have anti-CCP antibodies, they found that there was an increased prevalence of pulmonary abnormalities in seropositive individuals without arthritis, both by spirometry and high-resolution chest CT scanning. They found that airway abnormalities were detected in 76% of autoantibody positive subjects, but only 33% of autoantibody negative controls. These included bronchial wall thickening, bronchiectasis, central lobular opacities, and air trapping. These data were published in 2012 by Demirel and colleagues in Arthritis and Rheumatology. They also identified rheumatoid arthritis-related autoantibodies in the sputum of these individuals at risk for rheumatoid arthritis or with early rheumatoid arthritis. They obtained simultaneous serum and sputum samples from 21 healthy controls, 49 at-risk subjects without inflammatory arthritis, 23 of whom were seronegative and 26 seropositive, and then 14 patients with seropositive rheumatoid arthritis of less than 1 year duration. They tested paired samples for anti-CCP antibodies, rheumatoid factor, and total immunoglobulin G, M, and A. They found at least one autoantibody in the sputum of 39% of the at-risk seronegative subjects, 65% of the at-risk seropositive subjects, and 86% of subjects with early rheumatoid arthritis. The rate of positivity for anti-CCP antibodies and the median number of autoantibodies was higher in sputum than in serum, suggesting that rheumatoid arthritis-related autoantibodies may be generated or sequestered in the lung in at-risk individuals or individuals with early disease. These data were published by Willis and colleagues in Arthritis and Rheumatology in 2013. Now, given that background, the question is, what is producing these anti-citrulline peptide antibodies in the lungs of patients at risk for or with early untreated rheumatoid arthritis? There have been anti-citrulline antibody reactive cells identified in the lungs of rheumatoid arthritis patients in ectopic lymphoid structures and in bronchial biopsies of ACPA positive rheumatoid arthritis patients compared to ACPA negative rheumatoid arthritis patients. The aim of this study by Dr. Joshua and colleagues was to look for citrulline reactive B cells in the lungs of individuals at risk for and with early untreated rheumatoid arthritis. Now, these citrulline reactive B cells have previously been identified in synovial fluid, but not in bronchoalveolar lavage fluid from patients with early untreated rheumatoid arthritis or at risk for the disease. To look for this, they identified 4 at-risk subjects who fulfilled the 2010 ACR-EULAR criteria, who did not fulfill the ACR-EULAR criteria, but who had musculoskeletal symptoms and were on no anti-rheumatic drug therapy. They found patients who fulfilled the ACR-EULAR criteria who were either ACPA positive, 3 individuals, or 5 individuals who were ACPA negative, all with symptom duration of less than 1 year. And they performed bronchoscopy on these individuals, bronchoalveolar lavage, and obtained cells. They isolated and sorted the CD19 positive B cells, and then they analyzed the sequence from these individual cells for heavy and light chain variable region, amplifying these, and then transfecting the genes for the heavy chain and light chain into HEK293F cells. They then screened these cells, and they first found that there was a higher proportion of CD19 positive B cells in ACPA positive individuals, both at risk for rheumatoid arthritis and with early rheumatoid arthritis. When they looked for these cells, they found that by identifying cells that expressed immunoglobulin on their surface with mutations at N-glycosylation sites or high variable gene mutations, this selected for ACPA cells, or cells that were likely to be producing ACPA. And they found that there were 2 patients at risk for rheumatoid arthritis and 3 seropositive patients with early untreated rheumatoid arthritis who had B cells that were that had ACPA on their surface. And they then created monoclonal antibodies, or produced monoclonal antibodies from these lymphocytes. And they found that the specificity of these antibodies were for a number of different citrullinated proteins, citrullinated fibrinogen and citrullinated vimentin and citrullinated filigrin. 2 of the subjects had B cells that made anti-filigrin antibodies, and these are the antibodies that Sparks and colleagues identified as being predictive, perhaps, for interstitial lung disease in patients with rheumatoid arthritis. They found that these monoclonal anti-citrullinated peptide antibodies cross-reacted to acetylated and carbamylated antigens, as has been found for ACPAs in patients with established rheumatoid arthritis. They then looked for functional characteristics of these ACPAs, and they activated neutrophils with ionophore and found that several of these ACPAs bound to activated neutrophils, but not to non-activated neutrophils, perhaps contributing to netosis. They also found that by challenging synovial fibroblasts, they were able to induce fibroblast migration with 2 of the 4 ACPAs that were produced from these patients' B cells. They also found that 2 of the 4 ACPAs promoted osteoclastogenesis when they incubated the ACPAs with macrophages in the presence of MCSF and rank ligand. They were able to differentiate the macrophages into osteoclasts with ACPAs from 2 of these patients. So their findings were, for the first time, demonstrating that there were citrulline reactive B cells present in the lungs of early untreated rheumatoid arthritis, as well as patients at risk for developing rheumatoid arthritis. The ACPAs identified in the lung were similar in properties with high variable region mutations and mutations in Fab glycosylation to ACPAs from synovial B cells from patients with established rheumatoid arthritis. They found that these ACPAs cross-reacted to acetylated and carbamylated antigens, and that there were variable functional properties binding to activated neutrophils, promoting fibroblast migration and macrophage differentiation into osteoclasts. So interestingly, B cells are present in patients with early untreated rheumatoid arthritis at risk for developing rheumatoid arthritis, which probably produce the ACPAs that have been identified in sputum and in saliva from these individuals in earlier studies. The specificity of some of these antibodies is for the citrullinated filaggrin, which is similar to what Jeff Sparks and colleagues have identified as a risk factor for interstitial lung disease in patients with rheumatoid arthritis. And there are functional characteristics of these antibodies that may contribute to the pathophysiology of interstitial lung disease with fibroblast migration, neutrophil activation, resulting from these anti-citrullinated antibodies. So the story of interstitial lung disease in rheumatoid arthritis and at risk for patients for rheumatoid arthritis continues to develop. It looks as if the lung is the alpha and the omega of rheumatoid arthritis, where the earliest features of rheumatoid arthritis may originate in the lung, and interstitial lung disease may be an extra-articular complication in established rheumatoid arthritis, leading to morbidity, cancer, and mortality in some patients with rheumatoid arthritis. So here is a wonderful abstract presented from the Karolinska Institute, number 1445, which demonstrates that the lung is the alpha and omega of rheumatoid arthritis. I'm Jonathan Kay. For more information about this and other abstracts, please join us on Room Now, and I look forward to seeing you again with our rheumatoid arthritis faculty panel tonight, highlighting the various rheumatoid arthritis abstracts from day 3, Sunday, November 8th at ACR Convergence 2020. I'm Jonathan Kay.